keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
Hello, my name is Dr. Vaskan Dilsizian. I'm Associate Editor of JACC Imaging. With me in the studio is Dr. Dorbala. She's an Assistant Professor at the Brigham and Women's Hospital and Director of Nuclear Cardiology, as well as Dr. Raymond Gibbons from Mayo Clinic. Welcome. In this issue of JACC Imaging, you have a very interesting paper where you talk about incremental value of gated myocardial perfusion rubidium PET imaging over clinical variables as well as ejection fraction. Perhaps you can summarize the patient population and your findings, and maybe we can talk about ejection fraction reserve as a component of the prognostic impact.
Sure. Basically, we studied 1,432 patients who were referred to our lab and underwent vasodilator Rubidium-82 PET imaging. All of these patients were referred for clinical indications. Majority of these patients were symptomatic, and what we looked at was the incremental value of perfusion variables over clinical historical variables and rest ejection fraction. And the results that we found showed that the cardiac event rate for a normal Rubidium-82 myocardial perfusion study is less than 1%, and the event rate increased gradually from mild to moderate to severe myocardial perfusion abnormalities.
And these findings are quite similar to what we've been experiencing with myocardial perfusion SPECT imaging, is that correct?
That is correct. And the survival curves look very similar to what's been published with SPECT literature. The only difference is that the patients included in this study were only patients that underwent vasodilator PET imaging.
Okay. Now, the other important part of this was that you also showed incremental value of perfusion imaging to resting ejection fraction in a multivariate analysis, as well as functional reserve predicting outcome. Could you talk about that data as well?
Yes, that is right. So, in general, most of the symptomatic patients, by the time they arrive in the PET lab, usually have an assessment of ejection fraction. So it was important for us to show that perfusion imaging added value to historical variables plus rest ejection fraction. In addition, we also looked at changes in ejection fraction from rest to peak stress. And in a previous publication, we had found that patients that have significant ischemia or severe multi-vessel disease or left main disease have a drop in ejection fraction from rest to peak stress. So we extended the same findings to the prognostic paper and found that patients that improve their ejection fraction during stress tend to have a better outcome compared to patients that do not improve their EF.
That's fascinating. Dr. Gibbons, with your extensive experience with exercise MAGAs in the past, drop in ejection fraction during exercise is important both for detection of disease as well as prognosis. Could you explain to us, when we talk about vasodilator stress, it's really not exercise stress, it's vasodilation. How does vasodilation actually cause drop in ejection fraction?
Well, I think it's important to realize that a small minority of patients who are studied with vasodilators will actually have electrocardiographic changes to suggest that they have true ischemia. But there are probably a larger percentage of patients without ECG changes who do have some ischemia. And in this particular study, most of the patients were studied with dipyridamole. That has a far longer time of action. And we know from the early literature with dipyridamole echocardiography that a fair number of patients studied with that vasodilator actually have regional wall motion abnormalities and global dysfunction to suggest that they have ischemia. So I suspect that most of the patients here who had that finding actually had some ischemia, and it was because of the prolonged duration of dipyridamole.
Now, in the advent of new A2A receptor agonists, regadenoson, as a lot of laboratories like ours, we use adenosine. Should we be anticipating similar findings, or should we be cautious?
I think we should be cautious about extrapolating these findings to adenosine because of its much shorter duration of action. And only a minority of patients in this study were studied with adenosine. I don't really think we can actually be certain that the overall findings apply to them. We simply don't have enough information about regadenoson with respect to the induction of ischemia or the duration of action to know where that fits in
That's great. In conclusion, then, this to me is exciting because for the first time in the literature, if I'm correct, we are actually showing incremental value of ischemia to resting ejection fraction, which I think itself is important, but also functional reserve, having prognostic information. So where would you take this data next? What would you think needs to be done to make this more generalizable for all laboratories?
Yeah, I completely agree with the point that majority of the patients in this study were studied using dipridamol, and it should be important for everyone to keep in mind to not extrapolate these findings to other stress agents. Personally, I do believe that the next step in this would be to look at correlation between coronary flow reserve in relation to changes in ejection fraction, because we know from previous literature that increases in coronary flow are important to increase contractility with vasodilator stress.
That's great. Dr. Dorbala, Dr. Gibbons, thank you very much. It was a great discussion, and we look forward to having future data looking at flow reserve both in relative terms and in absolute terms, and see how they correlate with functional reserve changes. Thank you again.